Um, I'm going to skip by this slide because I want you to be looking at these pictures when I talk about the just clear differences between the extremely preterm child and the term child. And I recognize that some of this is redundant, so I won't take too much time. But the physiological flexion that we see in the term infant is just a result of the confinement immediately pre-delivery. And that predisposes those babies to a nice midline orientation, that nice return to flexion after active extension. You can, at that point, Sandy and I do a lot of test of infant motor performance on kids just as they're ready to leave the NICU, getting close to term, at term, just a little bit over term. You can elicit a subtle riding reaction already at term. In term babies, you want to support them pretty well and you don't test it too much, but kids are already, they're wired to deal with gravity when they arrive at term. On the other hand, the kids that are really preterm, they're very floppy, they succumb to gravity, they're pretty much laying against the surface that they're supported on. Their movements are more twitchy, for lack of a better word, not smooth. They don't have the opportunity to move that much. The midline orientation isn't there. Most of the time their head has to be turned so that the physicians and the caregivers can provide the life-saving supports that they need. There's just so many things. Their resting posture is more frogged, more extended. Any flexion that they do is with great effort, not through full range. There's just a lot of differences that, like we said with feeding, never really get made up. A lot of babies come close. Same rules apply that Dr. Needleman and Holly talked about, everybody talked about. The more preterm kids are, the greater ground they need to make up. Therapeutic positioning in the NICU, I mean, I think the staff in the NICU do an awesome job of trying to emulate that intrauterine environment. They provide boundaries that are as close to the kind of boundary the child might be experiencing still in the NICU, but they need access. And they need to be able to provide the kind of life-saving supports, again, that the kids need. So as the kids get older, the longer they've been there, a more active movement is allowed, and that helps develop muscle tone. And there is a developmental component to muscle tone. They start out very, very hypotonic, but there's always going to be that wide range, and at some point, muscle tone is what muscle tone is. So we're going to talk about muscle tone because our reports in the NICU speak to muscle tone, and a lot of the reactions that we can elicit or that we observe in the baby are a direct reflection of the muscle tone that they're demonstrating at the time. And even before we're doing the discharge testing on kids, we are sometimes called up to look at kids who appear to be reacting or their muscle tone is not even what the nurses are expecting to see, because they take care of lots of babies who are born preterm, and they have a real good sense of what kind of movement patterns are typical at what stage of care that they're getting in the NICU. And for example, I mean, there's a range. Hypotonia can be extremely, extremely low tone. And when we see them toward the end, they're the kids that we describe as having a lot of slip through. And I looked this up because it's such a goofy term, slip through, right? That's what it is. It just, you feel like they're going to fall through your hands. When you lift them up under the axilla, you feel like they could slip out of your hand as easily as you can hold on to them. Slip through and just not being able to lift anything off the bed. They succumb. They just succumb to any surface that they're on. That's hypotonia at its worst. Now, that's not to be confused with flaccidity. And we have a baby in the unit right now, actually, who was born essentially flaccid in the lowers. And it took a while for them to discover, this baby wasn't born in our unit or our hospital, but there was a cervical mass that was actually limiting the signals that the nerves were sending to the muscles in the lower extremity. The reports described moderate hypotonia, but the mother described no movement. And a couple of reports described atonia. So Hypotonia, I find that a lot of reports will say normal movement, normal tone, and it just means they move. It just means all four limbs are moving. It doesn't really have that qualifying characteristic that we'll assign to it later. Hypertonia is, of course, stiffness, muscle stiffness, and hypertonia can become spasticity, and Amy will speak to that a little bit more as we talk about CP. Hypertonia might just be a reaction to pain, might be a reaction to having a hard time breathing. You just really can't tell. And then some kids, you see fluctuation, and if you're seeing fluctuation on the way out of the unit, then you might, what you see in that infant is whenever you touch them or when you're trying to guide their movement and when you're trying to support them, they don't know how to react to it, and they kind of push into it or they push away from it, or they just don't seem to know how to react or how to activate muscles. So in general, the babies that we're dealing with in the NICU just don't have a lot of control over their muscle tone. They don't, and it's our job to understand what we see in relation to the situation that we've got. So physiologically, we tend to be more low tone, more lethargic, more just kind of dull in our effort, our motor effort, when we're tired. Kids in the NICU obviously are ill. They might be fighting infection. They might be struggling to breathe. Recovering from a seizure is going to change what's a typical pattern of muscle tone. And then just arousal makes a big difference. A stressed system is going to show higher tone. So we don't really spend a lot of time trying to assign a characteristic or a label to muscle tone until the baby's past that acutely ill stage. And then there's that range of motion issue too. Muscle tone mediates range of motion to some extent, but there's also joint factors, bone, joint, muscle factors that impact muscle or range of motion, and also the integrity of the nerve supply to the associated muscle. I just talked to you about a flaccid child who didn't have the nerve supply he needed to move the legs. But kids born with spina bifida or myelomeningocele obviously have a point at which the nerve supply is either distorted or missing. And that tends to be really confusing. You see a foot that's pointing its toe all the time, or I guess the one we saw most recently was dorsiflexed only. And it really bothered the nurses. Now, you can have atypical muscle tone superimposed on a spina bifida, lack of innervation. So, and that's what we have in the case that we have right now, is we have atypical muscle tone affecting the movement patterns in the upper extremities, and just a plain lack of innervation distally in the legs. So we're always looking at the big picture when we're looking at muscle tone. Range of motion has a relationship to muscle tone. We're not necessarily going to do any active range of motion in the unit. We aren't anyway. But we encourage active movement to incorporate full range when we can. And we help caregivers understand how we can assist a child through partial range of motion so that they can use the strength that they've got in an active assistive sort of pattern. So those are all words that we use a lot, and we feel like a picture is worth 1,000 words, so please tell me I can activate this. This is a low-tone child. Most of the time when they leave the unit, they're low tone. And this little sweetie, you can see where gravity is just hard on him. He wants to crawl. He's motivated to get to where he's going. But man, does it work. And he's incorporating all kinds of accommodative movements so he can keep in contact with the surface, because honestly, he can't lift away from the surface very easily. And sort of inching ahead. Here's some of that sound making that Beth wants. Yay! So see, I was told that y'all wanted to see what happened after they left the unit. This is a little guy that is pretty hypotonic, and you saw glasses on a real little guy too, so there's probably some residual ROP or some kind of vision impairment that he's struggling with too, which will also impact your motivation to move. Okay, so just in general, and hypotonia is typically what we are documenting when the kids leave the unit. It's unusual to see increased muscle tone, sometimes fluctuating, sometimes unusual reactions to being handled and moved or documented, but hypotonia is most often what we're documenting as something that we have concerns that might interfere with their ability to meet developmental motor milestones. So what these kids look like is and I have a couple more videos, they appear weak because they just have a harder time activating. They have to work a lot harder to gain control over movement in all postures. They initiate movement more slowly. Sometimes they look high tone to physicians because they initiate in a quick burst and it's boom, but they can't sustain it. They just let down really quickly because it takes everything they've got to do that quick burst. Joint laxity and hypermobility is very common, and one thing that makes me crazy after all these years in the business is if we think we can fix hypermobility. We can't fix hypermobility. We can help muscles get stronger. We can help kids use the muscles that they've got, but we're not going to reduce that hypermobility that just complicates, it makes them higher risk for injury, frankly, if they're trying to be very motor oriented and they have low tone. These kids stiffen their muscles as a result of their effort to stabilize and kind of get control, and we have a video where you can see even some back kneeing that happens when the kids are stacking. Less activation, it's hard work. You could see that little guy, he just wanted to get to the toy. It's hard work to move when you've got low muscle tone. And they lost out on all that early confinement that also really taught their skin where their boundaries were and really taught them about themselves. So these kids really do start out at a disadvantage. This is a little guy who is learning to crawl. He's also low tone, which you can sort of see his knees are a ways apart here. He's up in quadruped, which is pretty impressive. I'm sorry? Oh, this is them talking. I thought somebody was talking to me. I tried to turn the volume down so it wasn't too much. But see how he needs lots of rest in between effort? And this is a little guy who we know, because this is an old video, grew up to be developmental coordination disorder profile. So you can see him trying lots of different things to get motor and forward. He's got to rest here. Man, that gravity is hard. Okay, I'm back on my hands and knees. And I got forward a little bit. I'm sorry?
What's the purpose of the gel pillow? To challenge him a little more?
I don't know. Amy, do you?
It's actually a toy that's filled with water, and then it has little floating things, so they move when he touches it. But it was just to bring it.
It's just to put the toy up higher. Nothing magic about it. Yeah. So I don't want to take up too much time showing that. This is another, previous. I do want to show this, just to show some of the, this is a little girl with marked hypotonia pulling to stand. And everything about this little girl's interaction is just sort of sluggish. That's a word that we often use to describe kids with low muscle tone. But I'm going to play this long enough for you to see her getting back down. And watch for her back knee. See, boom. She's stacking. She's standing on locked knees right now. But she shifts. And in a second here, or in a few seconds, she'll get down. She's paying attention to the person with the camera. And she's lowering. And she's lowering. And she's going to get to sitting. She knows it works. You can tell that she knows the floor is down there. And she's down. That was her strategy. And she had the range of motion available to do it, and it was functional for her. So these kids come to us with the referral that says motor incoordination is a problem. Developmental coordination disorder, just by definition in the DSM-5, are kids who have motor development that is not in line with their other development. And there's no other diagnosis that better explains or is a primary diagnosis. So I've talked to Dr. Needleman, Dr. Ellis, and Dr. Allen, Holly's supervisor, about why don't we see developmental coordination disorder as a diagnosis very often, because we don't. We just don't see that around here. And the answer is because most of the time it's a comorbidity. Most of the time these kids have more than just motor incoordination. There's some learning problem, they're on the spectrum, there's other issues going on. But what we get the referral for is motor incoordination or concerns about motor coordination. And kids with low tone, these are the things that we see. They just have trouble getting things timed and figuring out how much is enough. They're either going at it too hard and too fast, or they're not going at it hard and fast enough, or they just can't figure out how to approach it. A lot of difficulty with motor imitation. You heard Beth talking about how important imitation is. They can't get organized. They can't figure out how to get their body to do what they want it to do. Holly talked about that too. I know what I want to do. I know what I want to say, but how do I get that motor plan going? Paul referred to motor plan. Paul's first love really now is kids with developmental apraxia of speech. Those kids know exactly what they want to say, and sometimes they're talking a mile a minute, but you can't understand a single thing that's coming out of their mouth. They can't get the muscles organized to say what they want to say. OTs get a lot of referrals that their play skills aren't good. It starts with self-feeding. They can't make friends with a spoon. They can't. They're not interested in coloring. They can't figure out why in the world you would color because, well, you know, that's early communication, guys. Coloring is the first time that the kids have a two-dimensional representation of an idea or a thought that they have. We don't have to see it. They're talking to us about it. They're saying, look at picture of you. And you say, awesome, it is. Because eventually that picture is going to take shape and it's actually going to look like whatever they're describing to us. You know, that's the early communication. And then, of course, handwriting is when everybody panics because kids with developmental coordination disorder have a lot of difficulty with handwriting. We also have some videos here, and I don't want to take too much time, but the bottom line with kids with motor incoordination is that if the skill has to be taught, and you have to learn to handwrite, and you have to learn to skip, and you have to learn to button, and you have to learn to zip, you have to be taught those things, that's what they have the greatest difficulty with. And of course, we've already talked about all these things. The literature is very clear in that it's associated with specific learning disabilities, articulation language problems, ADHD, and what we're most concerned about now is some of the emotional fallout. These kids with motor difficulties, I mean, they're walking. They walk. They can do basic motor skills, but they don't do them like kids who are well coordinated. And you know how much attention people who are athletic get for their motor skill. We just don't think this should be like a social deal breaker. that kids are not as coordinated as somebody else. And this is, I mean, I've always been all about the underdog anyway. And this issue makes me just a little bit crazy that motor things matter so much all the way through school, and we let it. And all the literature in my, Cheryl Masuna is an OT in Canada who has spent her entire career working on this issue of developmental coordination disorder, and her research has shown absolutely without question over 25 years that this is a chronic health problem. This is chronic. It's not going to go away. We can't fix motor coordination problems. We have to figure out how to support it. And she has a lot of literature out there. CanChild, which is something on my reference list. I'd go to that website if you're at all interested. They have a lot of side-by-side videos comparing well-coordinated youngsters with poorly coordinated youngsters and a lot of support activities in place. It's a wonderful website, and they've got lots of great literature out there. But I also really like this image because it talks about some of the fallout of kids who are not competent motorically. They don't engage. They choose to be inactive because they don't get made fun of. They don't have to save face. So they're not very active, and then it just becomes this horrible, vicious cycle of if I don't do it, I won't get made fun of, but then I never really learn how to do it, and maybe they're in an environment that doesn't promote a lot of physical activity. But you'd like them to be at least a little bit competent. And this young man, and I've got a few short videos of him, is a graduate of a NICU, I believe, here in town. I don't think it's ours. I'm not sure. His name is Alex. His parents are very generous about letting him videotape. He was a 22 weeks, 6 6/7, we think, preemie. His primary diagnosis now, he's 9. I think he's 9 in these videos, right? They're pretty recent. His primary diagnosis now is, doggone it, ASD. He's on the spectrum. And we think probably developmentally delayed and maybe more in special education than not. But he very much, in my mind, fits a pattern of developmental coordination disorder as a comorbidity. He's struggled with fastenings. They're farmers. The family is farms. And his father said, this is a legitimate effort. He's trying very hard. He's trying very hard to do this hopscotch activity. But you can see he's low tone. He doesn't have a good sense of his own body or how to time. Dribbling, something that he should be able to do. It just is not clear to him what he needs to do to make it happen.
I want to see your best jumping jack.
That's Amy.
Let me see.
And they do jumping jacks in gym class. I mean, PE class, sorry, giving my age away there. It was gym class when I was growing up. See, it's just hard. It's just truly hard for him. And
Doing really fast.
what I started to say was they live on a farm, and his dad said that at one point that he just wanted Alex to help pick up sticks from their yard. They had apparently a big rainstorm, and there were lots of branches laying out, and he thought, well, surely he's capable of helping with that. And it was hard for him to navigate, okay, there's a stick, go down, pick it up. Something simple like that. It was very challenging for him. But if you can appreciate, where he came from at barely 22, well, almost 23 weeks maybe, to now, he's a miracle. He's an absolute miracle. So, and I think you're up, aren't you? Yep. This is where we trade off.
Hi. I'm your last one. You'll be done soon, I promise. And just for those PTs in the audience, this might be a little bit of a review, but I'll go quickly as much as I can.
So in thinking about these premature babies that we've been talking about all day, we know that they're at high risk for developing cerebral palsy just from their medical course, from the high chance of damage to the certain parts of their brain. We know that fragile parts of the brain surrounding the ventricles, as you saw this morning with Dr. Needleman, that's the highest risk for these babies. Many of these preemies develop movement difficulties. We've talked about it with hypotonia. Sometimes you see them in the NICU. Sometimes you don't see those movement difficulties until later on. Sometimes also they'll have some low tone and it'll appear to kind of go away. So they get home, their parents are playing with them, they seem to be getting better, and then you'll see kind of that increased tone that we talked about with the hypertonia develop later on. And so we just need to be aware that those things may come a little bit later, and we want to be observant for that. There's a systematic review that was done in 2018, before I get into this, by Pascal, and I thought it was interesting because they looked at prevalences of motor and cognitive delays in very preterm, and they looked at less than 32-week gestation babies and very low birth weight babies of cognitive and motor delays. It's more recent, so they looked at the last decade rather than, so these babies were born before 2006, so looking at that past decade. What they did was they looked at their development at 2 years of age. They looked at, usually, most like the Bailey is what they looked at. Started with 2,400 articles, and they narrowed them down to 30, which is a lot. But in those 30 articles, they were looking at over 10,000 infants. And when they looked at the motor delays, they found that about 20% of those kids had motor delays, which is quite a big number. But then they went on and they said, okay, so there's 20% of them have motor delays. How many go on to develop CP? And in their calculations, when they pulled all their information together, it was 6.8%. And I was kind of shocked with that number, honestly, because I think of, oh, these babies are coming home from the NICU. They're going to, most likely, most of them will develop CP. Not the case. So I just thought it was really surprising. It doesn't mean that they're not going to develop concerning risk factors or going to have movement difficulties. They will. They may. They're going to have lots of other, we've talked about today, lots of other issues that will come. But the diagnosis of CP in this particular study was only at 6%. So I just thought that was interesting to share. So their conclusion in this analysis was 1 in 5 very, very low birth weight kids will have some sort of motor delay, and only 1 in 15 will end up being diagnosed with CP. So looking just in general about cerebral palsy, most of you know what cerebral palsy is. We'll go over the diagnosis in a minute. But we want to look at a variety of things. We don't want to just look at neuroimaging. We know neuroimaging is a huge risk factor. The higher the insult, the bigger the insult, the more likely CP is going to develop. But we also want to look at the neurological presentation. We want to look at their muscle tone, which we've already talked about today. Increased muscle tone we don't normally see right away in the NICU or right post-NICU, but we do see that develop later on. Unusual postures. As an early interventionist, we often will go into the home and the parents will be like, oh, well, he really likes the right side. Like, well, how long has this been going on? You know, we have a left side over here. Well, it affects everything. Why are they not, all of a sudden, they're using just their right hand? Well, because they don't know about this hand because they're always looking to the right. So there's so many different things that impact that that we need to address that right away. Feeding difficulties we've already talked about. Reflexes, sometimes we see persistent reflexes too. Startle reflexes. One of the examples I have, I just started working with a child in early intervention and just came home from the NICU about 2 weeks ago, I want to say, having trouble sleeping. Well, that's not unusual. But what's happening is this baby is being swaddled. She gets out of the swaddle and startles herself awake. And this happening over and over all night long. This poor mommy can't get any sleep. So again, startles are we expect that to happen, but not to that effect. So it's a problem. So we look at imaging, we look at motor milestones, and we look at all these neurological effects when we talk about cerebral palsy. So this is a definition of cerebral palsy. I like it because it just shows the diversity. We're looking at permanent disorders. They cause problems with development. It's attributed to non-progressive disturbances. These disturbances happened early on. They're not going to change. And then these are some of the factors that we've already talked all day today about: communication, cognition, behavior, all those effects. On this slide, you can just see associated health conditions. Again, it's a review: communication, feeding, learning, vision, all of these associated impairments with cerebral palsy. I think we're all aware of these. But they do have a big impact on all these kids, not just motor. So this is just a review. CP it's a big term, but we're looking at a movement disorder in combination with all of these other effects too. It's not progressive. The injury happened. It's not going to change. But what I like about this is it says it's not unchanging. A lot of times families will say, but he's changing. It looks different now. The CP, the insult isn't changing. What's happening is the demands on the child are changing. So maybe the baby could roll and they could crawl, but now, well, why can't he walk? I thought he was going to be able to do all those things. Well, the demands are changing. You're getting up against gravity. You're getting bigger. Things are harder when you get older. So we do see changes happen, but the actual insult of the CP is not going to change. That's going to stay the same. Talking about kind of that stiffness that we already discussed, we will see increased stiffness. Like I said, it develops sometimes later. In relation to hypotonia, we will see that for stability, but then we also may see some increased tones leading to spasticity. So as an early interventionist, that's something that's important to observe, but to make parents aware to watch for. Is it hard when you change your baby? Can you get their legs apart when you change their diaper? Is that really hard? Yeah, I noticed that. I can't get his legs apart. Why is that? You know, just little things like that. What are you noticing when he gets excited? What does he do? Oh, well, he throws himself back and he extends. You know, so those are things that are maybe not terribly concerning, but they're red flags. We need to watch for those. Likewise, if they're not moving against gravity, well, he doesn't move. He just sits there, you know. Oh, well, let's figure out a different way to do this then. So those are really important first things that you can see, you can talk to parents about right away. Passive and active range of motion kind of leads into that. If they're so low tone, they're not moving, they may have that passive range of motion, but they may not be using it because they can't get to what they want to get because gravity is difficult. Likewise, if they have increased tone, they have spasticity, they may be stuck over here, they want to get over there, and the only way they know how is to arch and roll over like a log. So these are all, I'm talking in general terms, but things to look for. But strength is affected. If you're constantly, maybe if you have increased tone and you're constantly flexed, then you're not going to be as strong because you're just constantly flexed like this. You're not going to be able to extend to go that way. You're going to show some decreased strength. All these other things, impaired growth, bony abnormalities, and then biomechanics typically we'll see later on when kids are getting a little bit older. As they get up, start to move. You know, if we've had an asymmetrical course where we've got maybe one side's working better than the other, we're going to start walking a little bit differently. If you're having trouble extending your arms, you're going to have difficulty with other things. So biomechanics is definitely affected later on. Posture, mobility, and then sensory. I don't think we've talked a lot about sensory. In the NICU, you know, we're protecting these babies. We're keeping them stable. We want to keep them stable medically. And then, so they're getting the sensory that they need at that time. But when we get them home, we want to expose them to more. We want them to be able to feel things with their feet, with their hands. We encourage parents to do, you know, massage, those kinds of things. But we also want to allow them the ability to move themselves. So whereas in the NICU, we're containing them, when we get them home, we want them to explore. We want them to, oh, I can move my hand, and when I move my hand, I touch that thing. What was that thing, you know? And so they're learning not only about movement, but about environment, about, oh, that's soft, oh, that's hard. Oh, if I roll this way, I can touch it with both hands. So movement becomes much more important, and I'll talk about that in a minute. So when we classify CP, this is just a review. we look at distribution. Diplegia is a description of where the legs are more involved than arms and trunk. Hemiplegia, one side of the body is more involved, and quadriplegia, the whole body typically is involved, arms, legs, and trunk, and oral motor too. We can also define CP as in movement characteristics, so spasticity, which is the most common. We see the stiffness, the persistent movements. We can predict pretty much how they're going to move. Dyskinetic, we see more unpredictable movements. That's athetoid. Not as common with the preemie population, but we see kind of trying to find their way, trying to find their balance by moving everything they can. Ataxia is more of a balance concern. They get up, most when they get up, start moving, they have trouble balancing and coordinating. And that's also less common. And then hypotonia that we talked about also again. This first video on top is just of a little one. Oh, I have to use the mouse, right? You can just see her walking. I think you guys can all figure out which type she has. Spastic diplegia. You can see how she's scissoring. She's having difficulty coordinating those abductors. She's up on her toes. But she's moving, and that's my big thing. She's moving. She's walking. This bottom video, it shows another type. Oh, someone can shout out what they think after they see. Oh, I didn't stop that one, sorry. So he has more of a athetosis. So he's trying to figure out where he is, how do I coordinate, and you know what? The floor is just way more stable for me. I'm just going to go down there. Okay. So in the past, motor function limitations were described as mild, moderate, and severe. So it was really vague. So in 1997, Palisano developed this gross motor function classification system. I think Dr. Needham mentioned it this morning. What it does is it rates ambulatory function. It looks at how kids move in their environment, looking at standing, sitting, standing, and mobility with devices. Looks at abilities rather than limitations. And what it does is it distinguishes levels from 1 to 5. So the least affected are at level 1 and the most affected are at level 5. The emphasis on it is how do they perform in the home and in their environment, which is a nice way to look at it, looking at the ICF model, looking at function, overtime over different environments. It was divided into age groups. Initially, it was divided up until age 12, and then in 2007, they added 12 to 18, so all the way up to age 18. This is just a general depiction of the different levels. Each age level, each age has a nice descriptor, and on that Canfield website that Janice was talking about, they have great descriptions on there about each level that they're at. So it's a nice way of classifying kids that have cerebral palsy. It's used throughout therapy. It's used in research. I've seen it described in some doctors' reports lately, too, and so it's a nice way for all of the professionals to communicate about what does this child look like in a nice, functional way. So I don't know if we really need to go through each of these, but looking at these pictures, you can kind of figure out that level 1s can walk, go up and down stairs. They can do jumping, coordinated activities. Level 2 need a little bit more help, maybe using a wheelchair for long distances. You kind of move up. Level 3 cannot walk independently. They need a supportive device, and on up to level 5 where they're fully dependent on mobility devices from the caregiver. So, the other thing I was going to mention about that is gross motor development curves were designed from this GMFCS level, and for therapists, these are great tools. So they took the GMFM, which is a standardized assessment we use for children with CP, and they combined it with levels. So they made kind of these curves like the height and weight curves that you have at the doctor's office that showed, okay, if this child is a level 1 and they're this old, what should their GMFM score be? And so you can kind of track, oh, Well, if they're here and all the other kids that are at that age at GMFCS1 are here, or up here, am I following the track that is kind of what would be expected? So it helps guide therapy, and it helps also with parents. For example, if parents are, will my child walk, or how long will he walk, or do I need a different device to use for this child? You can kind of use those curves as a guideline. I get it. So I just wanted to talk briefly about early intervention. We've talked about getting early intervention involved early on. These are just generalizations, birth to 3, for kids that are preemies. I was just talking to Janice earlier. I work in early intervention in OPS, and we've been getting quite a few referrals from the NICU, which is amazingly awesome. But what we're finding lately is the parents are overwhelmed. We'll call them, and they're 2 weeks out or 1 week out of the NICU, and they're like, I know we need to see you, but I just want to know my baby first. And so just keep that in mind. We're getting in there, I promise you, but sometimes these parents are just like, I can't handle one more person in my home right now. And so it's just an interesting, not every family, but just keep that in mind as they're leaving the NICU too. So what we focus on birth to 3, mostly what I like to focus on is movement. Movement. They come from, like I said before, they come from the NICU where they're very stable. Parents are very comfortable because they know that nurses are taking care of them. This one particular family, the baby loves his tummy, which is rare. I came in and she goes, he won't lay on his back. He will not lay on his back at all, because in the NICU, he got to be on his tummy with a monitor. But now mommy has to put him on his back. And so she's like, what do? I can't hold him on his tummy all day long. I can't do that. And so now our focus is, okay, let's get him on his back. How are we going to do this? The other thing is, I just wanted to mention quickly, initiation of movement is huge. So we're used to doing things to these babies. Once they get home, we want them to do things. We want them to move, but we want them to want to move. We want them to initiate that movement. That's where the cognition is going to start to develop. That's where the socialization, the eye contact. If I move over here, if I touch you and then you respond, I'm going to get that eye contact. I'm going to get that socialization, and it's going to build in one big, overall development. So we can never say we're just doing motor. We're always looking at the whole child. I'm just going to breeze through this. Preschool, 3 to 5, a lot of you are school-based therapists, so this is not new. I just wanted to point out, once we get to 3 or even before 3, we're starting to see some of the deformities happen. We're starting to see contractures. We're starting to see some of those postures that maybe started to develop early on, maybe some scoliosis, maybe we're seeing some more contractures with their ankles or their hips. And so equipment becomes more important in the school. And getting them to be able to be mobile and be up with their peers. I could be a whole nother day on that. This little girl is just an example of one of the walkers that we use, but talking about trying to get up to the level of your peers, she's just walking down the hall.
1, 2, 3, 4, 5, 26 steps. 6, go. 7, 8,
She gets there. That's just an example of one of the walkers we use, just like I said, to get them up, get them moving, participating with peers. School age, big gamut, wide gamut. The big picture for me that I wanted to share here was we look at mobility. We want them to walk. Every parent wants their kid to walk. They want them to walk with the least restrictive item, maybe forearm crutches, if possible. They push. Sometimes the kids want it too, sometimes they don't. But then when we get to school, we have to consider fatigue. We have to consider they need to learn. So if I'm pushing this kid to use forearm crutches to go from the hallway to the gym and back, and they get back to the classroom and they're so exhausted, they can't do anything, what was the point? So we need to figure out, where do we embed these times that include mobility? and where do we wait? And where do we let them have that time to learn in the classroom? The other thing is fitness. Kids with CP are 2 times more sedentary than any other kid, than their peers. So let's talk about community involvement. Let's talk about swim lessons. Let's talk about all those things. Actually, in the Birth to 3 program, let's not wait here. But start that early so that by the time they get ready to transition out, it's already part of what they do every day. This is just another example. This little guy's in school. I'm going to skip forward. Just an example of a little guy in school. He's pretty handsome kid. He's got his crutches over here. He's got his plan. Just kind of an example of how he looks as he's moving around. I like that they're in the trash can. That makes me happy. So the movement may not be perfect, but it's functional, and that's the other important things to think about. Okay. And I already touched on this, fitness. There's many opportunities in the communities that, even for 0 to 3, we have something called Young Athletes Program, where we can get children involved in movement. We have usually PT students that come help us with that, and some PTs too. There's a lot of different programs, Challenger Baseball, Top Soccer, lots of activities out there we can get these kids involved with. And as they get older, we can start to do more things, like involving them in the gym or involving them with swim lessons and things like that.
First of all, I've been here with you guys all day, and I did not introduce myself. My name is Sherry Kimmy. I'm one of the clinical nurse educators here at the Women's Hospital in outreach and then also in our NICU. So I spend about 75% of my time in our outreach education department with a focus on NICU, creating things like this today. And then the other time I spend in the NICU as a resource and then also helping with our TIPS NICU follow-up clinic. So a couple things just I think are important for you to kind of know about me. About 4 years ago, I reached out to Dr. Needleman and said, I want to be a developmental care expert. What do I need to do? So we sat down and talked together, and I have a background in early childhood education. I have a son who has developmental disability. I had lots of experience in the NICU. The one thing that he thought that I was missing was something called the LEND program. So that is leadership education for children with neurodevelopmental and related disabilities. So I got to be exposed to some of the great people that we've heard talk today. And the reason I tell you that is because, especially for those, the staff that we have here from the NICU, is I think that kind of brought everything full circle for me. So when I hope that it benefits our staff as I educate people, just because I think understanding some of the struggles that our families have when you leave the NICU is so important and can help shape the way you care for them when they are there. So I think overwhelmingly that we all know that we can change outcomes with neuroprotective care in the NICU. That's huge. I think that we can change outcomes with educating our families and making sure that we include them in every aspect of the baby's care, because they're the ones that are going to take them home and care for them for the rest of their lives. And then just also knowing what resources are out there and available to your families, I think is really, really important for best outcomes. So just those few things I wanted to say, and then I wanted to kind of touch on some of the things from the speakers today. So one thing that I think is not focused on as much as I wish it were. You know, we talk a lot about the major morbidities and we talk about CP and different things like that. I don't think that people spend enough time really focusing on minor morbidities of kids, which we did talk about a lot of those today, some of the mental health outcomes, ADHD, you know, those types of different things, and how much that can change the life of that family when they're dealing with those things. I think some people, I think, feel like, your outcome could have been so much worse. Look at this. This is great. You're going to school. You're doing this. But, those things have such a huge impact on their lives day to day. And I think that's something that we kind of have to check ourselves and just remember that, especially when we get busy, taking care of these really sick kids and we feel like they're having a much better outcome than they could have. But remembering what the families potentially are going to have to deal with day to day. One of the things that Dr. Needleman, I think, really taught me is the power of hope. So you have a very hopeless situation, and I feel like he has kind of helped me understand how important it is to have hope in those types of situations. So that's something that I talk to some of our staff about with families. Some of those really, really sick kids we have, if you were to really sit down with that family and just really hit hard on what the reality is of their life could be when they leave, what motivates them to come every day? You know what I mean? Hope is very powerful. And we really don't know what kind of outcome these kids are going to have until we know, So, we've seen kids leave with grade 4 PVL and have fantastic outcomes. And we've seen kids leave with grade 1 bleeds that haven't had such great outcomes, so you really, really don't know. But just kind of keeping that in mind, I think it's important and very powerful for our families to just give them some hope. Another thing just keeping in mind is that a lot of our families are really in crisis mode when they're here, and I think it's easy to kind of see them in that mode and become very frustrated with them and maybe their desire to have control over situations and the things that they focus on, and that gets very wearing on the nurses. But I think most of us would be surprised at how we would react if we were in the situation that they were in. I think I would be an absolute nightmare as a NICU mom. None of you would want to take care of me, I can promise you. So just keeping that in mind and giving our families some grace, because they really are in crisis mode when they're here, some worse than others. And you really can't judge how someone perceives their situation. So, you might have one mom whose baby has hyperbilirubinemia and she just can't pull it together because this was not how she pictured this going. And then you might have a mom of a 24-weeker that you think, she's rocking this, and everything in between. So just giving our families grace, I think, is really, really important also. A couple other little things I wanted to mention. Some of these are questions, actually, I'll ask. Eye contact when you're feeding a baby. I think trying to get them in a position where they can have eye contact with you is really, really important. I think we heard a lot about that today. Talking to them, we've talked about that. That can help with language development later on. And I know we do that, we score our families for postpartum depression and anxiety disorders, but really paying attention to that. I think it also was pretty overwhelmingly today how important it is to have well moms, to have well babies. So getting them the resources that they need to so that they have the tools to go home and do what they need to do for their kiddos. And then lots of positive reinforcement for our parents. I know someone said that today too. When you see them doing something good, point it out. I think that really helps with their self-efficacy. When they go home, they're going to carry that with them, and they're going to remember that too. And let's see. I love how Amy mentioned about being able to still actively move. So when we position babies in the NICU, we still want to make sure that they can move. So we don't want to have them swaddled to the point where they can't move at all, because being able to move is going to help them develop their tone. So I thought that was something important to point out. And then one thing, just a plug for tips. I love tips. And I think some of our families don't always value what we do in TIPS clinic because they are being followed by a pediatrician, so they feel like they're good and they're covered. But for example, like Amy said, if there was a kiddo that just really prefers their right side and the parents don't perceive that as a problem, they may not point that out to the pediatrician, and the pediatrician may not notice that in their 10-minute check. Those are the types of things that are identified in TIPS clinic. So if you have the opportunity to talk to a family about TIPS, or if you have a family that refuses TIPS and you're here, I'd be happy to come down and discuss the importance of TIP with them further. Mm-hmm.
My own personal experience, I had 30-week triplets. We spent 5 and 6 weeks in the NICU, and we did TIPS clinic. And everybody puts their kids in their little like jumper room things, right? And that's when you like stick them when they need to like stay there and not be in your way. Dr. Needleman and I don't know who else was all there that day could literally tell me which one of my 3 children spent more time in a jumper room because of their ability to have trunk support. So it is that detailed things that they pick up on that you're not going to see at your pediatrician's office.
And I love that I feel like our team doesn't over-treat. That's something that I love and really appreciate, remembering back from when I was going to multiple appointments for my son, which is something that we talked about last year at this program. We had a parent panel, and that was something we kind of heard overwhelmingly. They were not prepared for the amount of appointments that they were going to have to navigate on a monthly, weekly basis. So I appreciate that he doesn't over-treat the patients that he sees. So little things like how often are they on their toes, you know, and if I want you to make note of that, and in a month, if they're still doing that, I want you to call my office, and then we're going to bring you back in. So not just boom, jumping right to services, but saying, okay, I want you to pay attention to this and watch it. And then also, you know, therapies. When we had someone who had private physical therapy and they were receiving therapy through the school system, and he said, I don't think you need to do all that, you know, because they're kind of driving themselves crazy driving to all of these appointments. And he's like, really, it's what you take away from therapy that you incorporate in their everyday life that's going to be the most valuable. So it's that kind of stuff that's just priceless. So just my little plug for TIPS clinic. But now, if you guys have any questions, I just kind of wanted to summarize our day a little bit. If you have questions for the speakers that we still have here, we can get those answered, and I would love to show you this video here at the end.
I have a question about your TIPS clinic. So we live in Sioux City, the 3 of us, and we have a lot of babies up there. Omaha is really too far for parents to come to. But any suggestions on like starting up a clinic like that, or guidelines or anything?
Sandy might be able to help us with this.
I'm not sure if Dr. Needleman would, be able to assist, or you guys could maybe come down and
Maybe Joni.
observe a tour, watch the clinic.
Afterwards, I'll give you my email, and then we can get in touch with Dr. Needleman, and maybe Joni could help us with that to get more information. It's a grant-funded program, so I don't know how that works, but yeah, right. Yeah, I'm not sure, but we can definitely get you more information on that. Any other questions? I have a couple questions. You guys don't have questions. Let me see. Janice, I wanted to ask you really quick, why do you think that kiddos have problems more with feedings when you start introducing solids? And do you feel like as they get older, because we do also hear in TIPS, when kids come back, they just stop eating. And do you think that because they have the larger oral cavity that it's harder for them to control the bolus? Is that okay?
We always assume that the transition to solids is difficult because of the texture.
Yeah, that's what I
They
wondered.
either have perception that they can't manage that additional bulk, or it's just a formation problem. It's just that much more, and they can't figure out how to form the bolus or transfer it out. We would love to know.
Mm-hmm. When you,
Sometimes the kids didn't do much mouthing with their hands, toys, they're just sort of ignoring their own mechanism altogether. So it's not just textures that are the issue, there's other developmental gaps too.
that's what I wondered, if they had problems with solids, if they have other sensory.
But see, you focus too much on the sensory element, then we worry about people going too hard on it and overwhelming a system that's already kind of confused and disorganized. So more sensory isn't always better. It's more a matter of how.
Right.
Make sure that you're real. Force feeding is not the answer.
Yeah, and that's something too that I think we have to just continue to do the best that we can with our families when they get to that point where they've, I had this just happen to me a couple weeks ago. She's like, listen, we've been here for 6 weeks, okay? And then we're working on feeding, and we were supposed to go home, and now we're ready to go home, And so I think we all can appreciate families that we had that they just get to that point where they're like, if I gotta, whatever I gotta do to get this kid to eat, we're gonna do it because we gotta get out of here. But and just helping them understand how important it is. I have lots of notes. I'm just looking at my questions. Oh, what about them only? So I hear that a lot in tips also, that they can only get them to eat when they're drowsy.
When they're drowsy.
Mm-hmm.
I just think they get too shut up. The mom's anxiety, the baby feeds off the mom's anxiety. They're kind of not comfortable with organization to begin with.
Mm-hmm.
They're not comfortable being held in a comfortable way. I'm always amazed at, we've had families come in and the parents are well educated and well put together, but they have no clue how to cuddle and hold the baby and make the baby feel comfortable. And that's, I don't know.
Yeah.
You're just always constantly guessing. That's why that slide with all the issues that contribute to how well food intake goes, it's real. It's real. Sometimes it's the silliest things, and it's often not fixable with one little change. So we just give them what they can digest to think about and try to change and support.
Yeah.
We've honestly told moms, you need to put on yoga pants and sit in a big fat chair and lift this leg so you can support. It's like, why is that hard for some? But it is for some, because that's just not their MO.
Mm-hmm.
They wear necklaces and dresses. Turn on the TV and make people quiet. Yeah, it's just, I think it's interesting.
Yeah.
It's just interesting.
Do you guys have any other questions? Okay, we're going to show the video. One of the reasons why I wanted to show this at the end too is because I feel like it's easy to also feel sorry for people in these situations, and I think that he's a great example that he has quality life. So I wanted to end with that. So here we go.
Hi, I'm Zach Danner, and the Cerebral Palsy Foundation asked me to help them promote the show Speechless by giving a list of my top 10 things I wish people knew about TV. I don't really know if I can come up with a list of 10 things, but I'm going to try. Okay, number 1. Just because I'm in a wheelchair doesn't mean that you can pet me like a dog. I'm not a dog, and I know it seems nice and I'm at dog height, but that doesn't make me a dog. And just because I like to pee outside sometimes, that doesn't make me a dog. And just because I won the Westminster Dog Show last year doesn't mean, oh my God. Not a dog. Number 2, I think it's pronounced cerebral palsy. I don't know if cerebral is a word. Number 3, it is hard for people with cerebral palsy to make lists with their fingers, so I'm going to stop doing it. Number 4, if you ask me what's wrong with my legs, the real answer to that is nothing. I have brain damage, so that's a little bit more exciting. Cerebral palsy isn't like, oh, that means your legs don't work. Some people with cerebral palsy are walking around just fine. Number 5, just because I have cerebral palsy doesn't mean I'm inherently inspiring. I'm inspiring because I'm an author, a YouTuber, and I have the biceps of a Greek god. Number 6, even though I have cerebral palsy, I still consider myself incredibly lucky. I have a great career, I have wonderful friends, and somehow I've managed to make a living while not getting up before noon most days. Number 7, just because your grandson has cerebral palsy doesn't mean I know him, Ethel. I mean, we don't even live in the same state. Number 8, Yes, I'm gonna need some help with some stuff sometimes. But just talk to me like I'm a normal 31-year-old guy who spilled a carton of chocolate milk on himself. Number 9, you are welcome to pray for me if you want, but I feel like having cerebral palsy is part of the reason I'm supposed to be here, and one of the tools that I can use to help people be a little bit more compassionate and open to people with differences. So it's just, I'm working with what I got there. And number 10, and most importantly, almost everything I've said is subjective, and you should just talk to more people with CP and see what they feel about it. Because I'm not a spokesman for all people with CP. People with CP are as diverse as all of humanity. So just go out there, have a conversation, and do what you can to educate yourself. So that's about as good a list as I can come up with on the fly, and I hope you learned something today. Or nothing. I don't really care. But remember to subscribe to the Cerebral Palsy Foundation and check out ABC's Speech List premiering September 21st. I think it's at 8:30, but I don't know for sure. And if you want to check out the pilot, it's in the description there. All right, see you next time. Happy learning. Bye.